All right, Cardiovascular Emergencies, Chapter 17. First thing we're going to talk about is a little bit of anatomy and physiology, and we're going to talk about how the electrical system works in the heart. So in the upper right corner of the right atrium, I guess, is a little area of cells called the sinoatrial node. And this pacemaker area generates electrical impulses at about 60 to 80 times a minute. And these electrical impulses spread out through the atria through something called intranodal pathways. And one of those pathways goes down to the atrioventricular node, or the AV node. And here the conduction pauses for just a moment before it passes down the bundle branches, the right and left bundle branches. You may have heard of a bundle branch block, and that's when one of those wires, one of those pathways is blocked a little bit. But these are the right and left bundles of His, and it comes down these bundles and then goes to the Purkinje fibers. Now in the in the SA node, electrical impulses are started at 60 to 80 times a minute. If for some reason that part is not working, the atrioventricular or AV node can take over, except they only send out electrical impulses at about 40 to 60 times a minute. So hopefully that will never start to work while the SA node is working. And then if both of those fail, the Purkinje fibers at the bottom of the ventricles can send out their own electrical impulses at a rate of about 20 to 40 times a minute. Now normally, that's not a problem. However, if the ventricles become what we call irritated, and a lot of times irritation is lack of oxygen because of maybe a blockage to one of the blood vessels of the heart, then those cells may begin firing off on their own. And every cardiac cell in the heart has the property of generating its own electrical activity, and that's called automaticity. If that happens down in the ventricles, though, that may then lead to a condition called ventricular fibrillation. And we need to stop that, and we learned about that in CPR class because we stopped that by delivering an electrical shock from an automated external defibrillator, and then hopefully the normal SA node, sinoatrial node, will kick back in and start working, and we'll have the normal heartbeat again. The blood comes from the body, from the bottom part of the body, the inferior part of the body. It comes up the inferior vena cava. From the upper part of the body, it comes in from the superior vena cava. These come and collect in the right atria. It then passes through the tricuspid valve, goes to the right ventricle, gets pumped out through the pulmonary valve into the pulmonary arteries. This is all deoxygenated blood, meaning there's no oxygen. It's kind of a darkish color, more bluish. Goes through the lungs, gets rid of the carbon dioxide, picks up the oxygen, and comes back through the pulmonary artery. This will be the only artery that, the pulmonary vein. This will be the only vein that carries oxygenated blood. Comes down to the right atrium, goes through the bicuspid or mitral valve. You'll occasionally hear people that have mitral valve prolapse. That's a damaged bicuspid or mitral valve. Goes down to the left ventricle, then gets pumped out through the aortic valve and into the aorta, and then goes off to the rest of the body. There's also a branch coronary sinus, coronary artery that comes off of the aorta right at the point where it leaves the heart, and that artery, the coronary artery, then takes blood throughout the heart itself. So you really have three kind of circles of circulation. You have the one that goes through the lungs, you have one that goes through the body, and you have one that goes through the heart. And you would think with all the blood going through the heart, it would have enough, but it doesn't. It needs its own blood supply. So you have a supply of coronary arteries and capillaries and then veins that supply the heart with oxygenated blood and removes the carbon dioxide. As far as going to the rest of the body, we're going to talk about these throughout the semester. I don't expect you to memorize each of these. I would expect you to know a few things like carotid, brachial, radial, femoral, popliteal, dorsalis pedis, posterior tibial, because those are all places that we will check pulses on a patient. When you get into advanced EMT and paramedic, you might start looking more at the veins because then we want to start IVs, and that's kind of cool. So the heart itself, as I said, has its own coronary circulation, its own blood flows, and it comes right off of the aorta as soon as the aorta comes out of the heart. And we have a right coronary artery that goes to the right side of the heart, and we have a left coronary artery that goes to the left side of the heart. Each of these then has branches. Now, the left coronary artery supplies the ventricles, and because of that, if the left coronary artery gets blocked, everything downstream from that will begin to die. So if you take a look at the picture here, you can see that that left coronary artery supplies a big part of the heart. It even goes all the way around to the backside, the posterior. So if all that starts to die, then the heart dies. So the left coronary artery is also sometimes called the widowmaker. So if you have a blockage of the artery right there, where the kind of where the dot is on the left coronary artery marker, a large part of that heart's going to die, and they're probably going to die. But just realize that the heart has its own set of blood vessels. Now, the blood itself has different components, and we usually break them into initially two-part. We have formed elements, and then we have plasma. And the plasma is the straw-colored fluid, and it carries electrolytes and proteins and nutrients and glucose and things like that. Platelets are floating around in it, although the platelets are part of the formed elements. The white blood cells make up a real thin strip, and then the red blood cells make up the majority of the formed elements. We can actually determine how much of each we have. What we do is we draw some blood, we put it into a centrifuge, and we spin it down, and it kind of looks like this on the picture. And you'll see that the bottom part there is the red blood cells, because those tend to be the heaviest. And that usually makes up somewhere around 40 to 44% of the amount of blood that we have. And then maybe 1% of it is white blood cells, and the rest of it is plasma. So we call this the hematocrit. And a hematocrit is the measure of how much of it is the formed elements, or what percentage of your blood is actually red blood cells. And males tend to have a little bit more than females, but it's usually running in the low 40%. If we measure this, we can sometimes see if you're losing blood somewhere, because if your hematocrit is very low, so maybe only about 35% of your blood is red blood cells, it's indicating that you're losing blood somewhere.
Normally, blood clots form in response to injuries which cause bleeding. Clot formation helps to conserve the body's supply of blood so that small cuts don't end up draining the body of all of its blood. The body's process for stopping the bleeding by forming a clot is called hemostasis. In this illustration, the blood vessel contains red blood cells, white blood cells, platelets, and tiny proteins called clotting factors. These components of the blood float together in a straw-colored liquid called plasma. When the vessel wall is torn open by an injury, blood begins to escape. In response to this damage, the vessel quickly constricts, reducing the flow of blood. This constriction lasts only for a few minutes, as the body puts in place a plug to stop the bleeding. Platelets soon recognize the injury and begin to stick to the damaged surfaces. This is called platelet adhesion. The adhering platelets change shape and release chemicals which keep the vessel constricted and draw more platelets into the damaged area. These platelets are said to be activated. Additional platelets arrive and begin to stick to one another so that a loose plug is formed. This is called platelet aggregation. When tissue is torn apart during an injury, blood is exposed to a chemical called tissue factor, which naturally resides on the surface of tissue cells, or may also be displayed on the inner lining of the blood vessel wall. This tissue factor sets into motion the chemical reactions of the clotting factors found floating in the nearby blood. Around a dozen different chemicals called clotting factors circulate inactively within the blood. When called upon, these clotting factors participate in a complex sequence of chemical reactions to ultimately produce tiny strands of a strong material called fibrin. Fibrin strands form in and around the loosely arranged plug of platelets, and eventually form a meshwork which tightly binds the plug together. This meshwork keeps the platelets from being washed away by the flow of blood and makes the platelet plug more watertight. Red blood cells and white blood cells become trapped in the meshwork as it forms, giving the plug its characteristic red color. The overall process of forming these fibrin strands to solidify the clot is called coagulation. So within a matter of minutes, a sturdy plug is formed to arrest the outflow of blood. But too much coagulation activity allows the clot to grow much larger than it should. Two groups of the body's own naturally produced chemicals help to limit the size of the clot. The first group blocks coagulation. These substances are known as coagulation inhibitors or natural anticoagulants. When these chemicals interfere with the reactions among the clotting factors, fibrin formation is blocked, and no new fibrin strands are available to hold additional cells to the clot. In this way, clot growth is kept to a minimum. The other group of chemicals keeps clot growth under control by cutting the fibrin strands and actually dissolving part of the clot. These chemicals are part of the natural process known as fibrinolysis. Fibrinolysis occurs as chemicals called plasminogen activators are slowly released from the inner lining of the damaged vessel wall. These plasminogen activators trigger the destruction of the fibrin strands that hold the clot together. So coagulation inhibitors can only stop the growth of the clot, but fibrinolysis can actually dissolve part or all of the clot. In fact, when the vessel is completely healed, the remaining clot is dissolved by means of this second group of chemicals. To sum up then, rapid clot formation is essential for conservation of the body's supply of blood. We've seen the constriction of an injured blood vessel, the formation of a platelet plug, the strengthening of that plug by the addition of fibrin strands, and the body's protective systems preventing excessive clot growth.
I thought he could do a much better job explaining that than I could. Kind of like that video. I'll try to find the link to it. I just haven't embedded my presentation, but I'll see if I can find the link to it and add it to our presentations. So that's what happens when we have damage to a blood vessel. But one of the things that we have found is with heart disease and acute coronary syndromes and myocardial infarctions, we have something that's very similar that happens inside of one of the coronary arteries. So normally our arteries are going to be like in picture A, and things are fairly open and clear, and we have pretty good blood flow. And then we do things like eat pizza and donuts and ice cream and all the good tasting stuff in life, and then we go from A to B. And if we continue to do that, then we go from B to C. And then something happens and the inner lining of the blood vessel becomes damaged or cracked, and your body's immune system identifies this and says, ooh, this is damage, just like any other damage to a blood vessel, and it then forms a clot and a thrombosis there. And when that completely blocks the artery off, then no blood's getting through there, and obviously everything downstream is starting to starve. And that's called a myocardial infarction. So what happens during a typical cardiac contraction or cycle? So the SA node will start to send a signal out, and this has caused the atria to begin to contract. And when this happens, the blood will move out of the atria through the valves and down to the ventricles. Then the ventricles, then there'll be a slight pause in the AV junction, or the atrioventricular node. And when that happens, that gives us time for the blood to get into the ventricles and stretch them. And if you remember the Starling effect, the further we stretch those ventricles, the stronger the contraction is going to be. Once it gets through there, then we can contract the ventricles, open up the pulmonary valve and send it out through the pulmonary artery. Goes through the lungs, comes back from the lungs into the left atria. Kind of the same cycle happens, but this time on the left side it goes through the bicuspid valve or mitral valve down to the left ventricle, and then it goes out to the rest of the body from there. But this makes a thump, 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 because the two atria contract together, and then the tricuspid and bicuspid valves will open. The blood will be forced down into the ventricles, and then so if it's a lub-dub, lub-dub, lub is the atria contracting, dub will be the ventricles contracting. When the ventricles contract, the bicuspid and tricuspid valves close, so the blood won't go back up into the atria. It'll only go out through the pulmonary artery and the aorta. Now, all this stuff is run off of electricity, and it has to do with sodium and potassium fluctuations. Normally, we have sodium on the outside of the cells, potassium on the inside of the cells, and if you have those in the proper quantities, then we can have electrical impulses. If that gets messed up, then we might have like a cramp. So all of this electrical impulse stuff we can actually see with something called an electrocardiogram, or ECG. And in lab, we'll show you how to hook this up so you can do this. You're not really taught to interpret ECGs in EMT class, but there's a couple of rhythms we want you to at least be familiar with. What does a normal rhythm look like? Then we also want you to know something called ventricular fibrillation, ventricular tachycardia, and another rhythm called asystole. So when the atria contract, the two chambers on the top of the heart, which started with the SA node, when we see those muscles contract, the sodium and the potassium fluctuation there shows up as a little blip called a P wave. Then the electrical impulse has a little pause, and you'll see after the P wave bump, it kind of flattens out. That's the AV junction where it's pausing there for just a moment. The electrical impulse then passes down the left and right bundle branches and goes down to the Purkinje fibers and then causes the muscles of the ventricle to contract. Now the muscles in the ventricle, because they have to pump blood through the heart, through the heart, through the lungs, and through the body, those muscles are much bigger and much stronger. So the P wave, which is the atria contracting, is a much smaller wave than the QRS complex, which is when the ventricles are contracting. So P wave, atria contraction, QRS complex, ventricles contracting. And then you have this thing at the end called the T wave. And I said that to have the electrical activity in the muscle contraction, you need sodium and potassium, and these will fluctuate or move back and forth. So what happens when a muscle contracts is the potassium will rush out, the sodium will rush in, the muscle will contract, and then we have these sodium-potassium pumps that will pump the sodium back out and pump the potassium back in and return it to its normal state. And we call that repolarization, and that's the T wave. That's the ventricles doing that. So you can almost imagine like you're flushing a toilet. So when you flush a toilet, that's your QRS complex. And then you have to wait for it to fill up again. And you wait and you wait and you wait because you got to flush it again. Didn't clear it out the first time. Well, you can't for a little while because you have to wait for it to fill back up. And that's kind of the same thing that's happening with the sodium-potassium pumps. And once we get to the top of the T wave, the very top of that peak of that T wave, we can then have another depolarization. We could have another QRS complex happen at that point. So that's kind of what a QRS complex looks like. Just a little side note on this, people talk about something called commotio cordis, and that's when somebody gets hit in the chest and hit right over the heart at just the wrong moment, and it puts them into cardiac arrest. And that happens when the baseball, the softball, the hockey puck, or whatever hits someone right when the QRS complex is happening. So between the QRS complex and the T wave, something strikes them in the chest. And this is just a millisecond that it happens, but it hits them at just the wrong time, and that will actually cause the heart to begin to fibrillate then. So people sometimes joke about martial artists and being able to kill someone with one punch, and you hit them in the chest and you stop their heart and all that. And yeah, if I could really tell where your heart was in your cardiac conduction cycle, and I could time it just within those milliseconds, I theoretically could hit you in the chest. Of course, you could theoretically hit me in the chest too at the right time. It could stop the heart. Now, I've never seen that happen in class or tournaments or anything like that, but it is a concern anytime somebody gets hit in the chest. We typically see this with like softball or baseball players down here, little league type stuff. I've seen it with hockey, or I can't say as I've seen it. I know it has happened at hockey games where they get hit in the chest with a puck. But that happens right between the QRS complex and the T wave. No, don't ask me to demonstrate it. So what is blood pressure? We have two terms that we talk about with blood pressure. We have systolic and diastolic. And we talked a little bit about this when we talked about shock. We know that systolic blood pressure is the top number and diastolic blood pressure is the bottom number. Systolic blood pressure is when the ventricles are contracting. So the squeeze of the ventricles forces the blood through the blood vessels, and that kind of stretches them out, and we feel the pulse wave of this blood flow at like the carotid artery, the brachial artery, the radial artery. And as the pulse wave passes through, we have a high number. And that's the systolic blood pressure is a measure of how strong the ventricles are contracting. Well, once that pulse wave gets through us and the ventricles are relaxing and filling back up with blood, then we have the diastolic blood pressure. And that's the amount of blood that's in the blood vessels just all the time. And it's really a good kind of correlation or measure of how constricted or dilated your blood vessels are. So if your diastolic blood pressure is high, it means your blood vessels are probably constricted. Of course, the problem is that means they're always under that amount of pressure. So if that pressure gets high, then there's running the risk that one of these blood vessels could pop or rupture. And if that happens in the brain, we call it a stroke. We used to say 120/80 was normal. They now want us to have blood pressures of 110/70. I think we still use the 140/90. If your systolic is above 140 regularly or your diastolic is above 90 regularly, you're considered to have hypertension, high blood pressure. Now, we've talked a little bit about inadequate circulation. We had a whole talk on shock, so I don't want to spend a lot of time on this. But just remember that every cell in the body needs oxygen and needs glucose, including the heart muscle cells. And if you're not getting enough perfusion, not getting enough blood flow, you're not getting enough oxygen, and you're not getting enough glucose. And we call that hypoperfusion. So that's the delivery, but also remember that we have to remove all the waste products. So carbon dioxide and other things that are used, or other waste products we have to remove from the cells. And typically either the liver changes them into something else, detoxifies them, or the kidneys filter them out and we pee them off. In the case of carbon dioxide, though, our lungs, we exhale it. A lot of that CO2 is transmitted around the body in bicarbonate ions, and then we get to the lungs, it converts to CO2, and we exhale it. So let's get talking about cardiac stuff that's really wrong with the heart. And we kind of lump all of this together in something called acute coronary syndrome, or ACS. And the reason we do that is that sometimes it's a little difficult in the field for us to differentiate between different types of heart problems. So cardiac compromise just means that something has happened, something's changed in the body, and the heart is not going to be able to work quite as well as it used to. Atherosclerosis. This is what we kind of talked about earlier when we had all this buildup of stuff in the blood vessels itself. And arteriosclerosis, building it up. Atherosclerosis is just kind of how flexible your blood vessels get. And anytime we have this buildup of this plaque inside a coronary artery, we call it coronary artery disease. Although this stuff happens other places in the body too. So you can have poor circulation in other parts of the body because you have a bunch of fat and cholesterol building up plaques inside of arteries going to like your feet or your hands or your brain or somewhere else.
Coronary artery disease. Coronary artery disease occurs when the coronary arteries are narrowed or blocked, reducing the amount of oxygen delivered to the heart. Two conditions, atherosclerosis and arteriosclerosis, commonly cause the narrowing or blockage of arteries. Atherosclerosis is a buildup of fatty deposits on the inner walls of arteries. This buildup causes a narrowing of the inner vessel diameter, restricting blood flow. Fats and other particles combine to form plaque. Arteriosclerosis is a stiffening or hardening of the artery wall resulting from calcium deposits. Often called hardening of the arteries, this condition causes the loss of elasticity, changing blood flow and increasing blood pressure. These conditions can facilitate rough surfaces, making them vulnerable to blockages. A large thrombus can cause an occlusion, or it may break loose to become an embolism and form blockages elsewhere. When blockage occurs, tissues may die, and in certain cases, this can be fatal.
Kind of a better graphic than maybe me explaining it, but that's what can happen. They ended up with this video actually showing what happens with a stroke. And we'll kind of talk about stroke in another chapter. But you can imagine this also happens in one of the blood vessels of the heart, and that then leads to a myocardial infarction. So the acute coronary syndrome, as I mentioned, we have these blockages. And if you look at like picture B or C, you can see it's pretty much all the way blocked, and maybe much more so than C than B. But if I've been going along doing my life just doing whatever I'm doing, and I get to the point where I'm at C, and you notice that it's pretty narrow. Well, that's okay, especially if I'm just like sort of sitting around watching television and not getting all that excited, not doing much. Maybe there's enough blood flow getting through that little narrowed artery that my heart's doing okay. But then when I get up to do something like mow the yard, and I have to exercise a little bit and work my heart a little bit, and it starts beating harder, well, now it needs more oxygen. It needs more blood, but the artery is already pretty narrow, and it just can't get enough through it. That then causes the heart to begin to go into anaerobic metabolism and start to cause some pain, and we call that angina. Now, if I sit down and rest, and my heart slows down, then it doesn't need as much oxygen, and the chest pain goes away. And I'm like, oh, okay, I don't know what that was, but it must be okay. And actually, it's a warning sign that something bad is going to happen soon. Now, unstable angina is a type of angina that occurs even when you're sitting down. So they're not exercising, they're not working hard, it just happens. It's really, well, it's nearly impossible pre-hospitally for us to tell the difference between unstable angina and an MI. We can sometimes kind of get a feeling, but we don't really know. Now, if we look at picture D, we see we have a clot that's formed in there and has blocked off the artery nearly completely, and almost no blood's getting through there. So whether I'm sitting down, whether I'm walking around the yard, whatever I'm doing, I'm not getting enough blood flow through that artery, and that part of the heart is dying. And that part of the heart is starting to hurt, and that causes the chest pain. And that's called a myocardial infarction now. And actually at this point, the cardiac cells are not getting enough oxygen and glucose. They're going into anaerobic metabolism. That is causing them to go into myocardial ischemia, which just means they don't have enough oxygen and they're starting to get damaged. And if they are not, or if that's not fixed pretty quickly, then they will die. And the term for the death of heart cells is a myocardial infarction. And the myocardium, you may be wondering what that is. There's 3 layers to the heart muscle. There's an epicardium, a myocardium, and an endocardium. The inner lining of the heart is like the inside of the ventricle. That would be the endocardium. The middle, the strong muscle part, is the myocardium, and myo means muscle. And then we have the pericardium, which is the sac surrounding the outside of the heart. So a myocardial infarction means your heart muscle cell is dying, or layer is dying. Just kind of a cool animation of what happens there. A whole lot better than what I can draw. So I mentioned the angina, So here we have a blockage to part of the heart. One of the arteries is partially blocked with atherosclerosis, but not completely. So again, when I start to exercise or do something more strenuous, like mow the yard or run up some stairs, then there is just not enough blood getting through there, so not enough oxygen, not enough glucose, and part of the heart starts to become ischemic and start to hurt. When I sit down and rest, it goes away. This is really what nitroglycerin is designed to do, is to help this thing, because it will help open up the blood vessels and restore more blood flow, and then hopefully take care of the angina. Typically, these patients are going to have chest pain, maybe a little bit of pain in their shoulder, jaw, and neck, a little short of breath, a little sick to their stomach. But the symptoms are not typically as bad as a myocardial infarction. They're somewhat mild.
Your doctor has prescribed you nitroglycerin. This medication is to be used if you begin to have an acute attack of chest pain. Nitroglycerin works by causing coronary arteries of your heart to dilate. This will allow more blood flow to your heart. If you begin to have an acute attack of chest pain, sit down. Place one tablet beneath your tongue and wait for 5 minutes. Do not chew or swallow tablets. If the chest pain is not relieved, place a second tablet beneath your tongue and wait another 5 minutes. If the chest pain is still not relieved, place a third tablet beneath your tongue and call 911 immediately. Nitroglycerin is also prescribed in a spray form. Directions for use are the same as nitroglycerin tablets. If you begin to experience chest pain, administer one spray beneath your tongue. If chest pain continues, you may administer a nitroglycerin spray every 5 minutes for a total of 3 doses. If chest pain is not relieved after the second dose of nitroglycerin, 911 should be called. Side effects of nitroglycerin are headache and low blood pressure, which may cause you to feel dizzy. These are common side effects and will only last for a short time. If you have further questions about nitroglycerin, please contact your physician.
So a little bit about nitro. We'll talk more about it in pharmacology, which I think is chapter 14, which we're going to get back to in here in a week or two, or 3. I'll have to check the schedule. But if we think somebody's having angina, of course we need to monitor the patient, assess to make sure there's no major bleeding, the airway's open, and then this breathing thing. We need to figure out oxygen. And I know the picture here shows this non-rebreather, and in old days, that's exactly what we would do. If we thought you were having a heart attack or chest pain, we put you in a non-rebreather. Everybody got a non-rebreather. In fact, if that was a registry answer, that was probably the correct answer, a non-rebreather. What we have found, though, is that by delivering high concentrations of oxygen, we can cause the blood vessels themselves, because they think there's so much oxygen, to begin to constrict a little bit. And there's also free radical oxygen. By delivering so much of it, it can damage cells. So we know that giving high concentrations of oxygen can be harmful. So like any other medication, we try to give the right dose. And we do that based off of the pulse oximeter. If the pulse oximeter is above 94%, we don't need to give any oxygen. Now, if they're short of breath, complaining of respiratory distress, they're in shock, we don't think we have a good reading on the pulse ox, then we want to go ahead and give oxygen. But for your typical chest pain, we don't need to do it anymore. Give them any oxygen period, or at most give them 1 to 2 liters, unless the pulse ox reading is low. Now, aspirin can help limit the size of that clot that might be forming inside their heart, so that's a wonderful thing to do. We want to give 3 to 4 baby aspirin or 1 adult aspirin, have them chew it up and swallow it, as long as they're not allergic to it and as long as they don't have any bleeding disorders. Now, they've already had one aspirin that day. We don't need to give them another one, but aspirin is one of the best things that we can do, and as EMTs, we can assist them with that. Now, if they have aspirin we can administer. If we have nitroglycerin, we can assist them with that. And that's their prescription. They kind of know when to take it. Just make sure you check their blood pressure, and their blood pressure is not too low or their heart rate's not too high, because that makes you think they might be going into shock. And then there's also the phosphodiesterase inhibitors, which are all the erectile dysfunction medications. They can react with nitro and make somebody's blood pressure drop really fast, so we got to be careful with that. And this is one of those times where getting advanced life support, getting a paramedic unit to meet with you would be a good idea, because we can do 12 leads and tell more about the heart and get some other medications. But really, this patient needs to get to a cardiac hospital, so a hospital that can do cardiac catheterization and go in there and clear out the clot. Locally, the only one that does that is North Alabama Medical Center. Now, an acute myocardial infarction is much more severe than an angina. An angina is kind of like a warning sign that an MI is about to happen. So the pain is typically in the chest. A lot of times, especially males more than females, will clutch their chest or hold their fist to their chest, and it'll go up into their neck and jaw and back. Now, it doesn't happen to everybody every time the same way. Everybody's a little bit different, but these are kind of the classic signs. And it's usually like a heaviness or a pressure or a tightness or a squeezing or someone sitting on their chest. And angina usually happens when they're exerting themselves and goes away a few minutes, 10, 15 minutes after they've sat down and rest. The MI, because the artery is completely blocked, it doesn't matter whether they're exercising or resting. The heart is still dying and there's still going to be pain. Usually with an MI, it's a little more severe. They also have some nausea. They're sick to their stomach. They're short of breath. They might be sweaty and pale. We oftentimes kind of see them looking like they're gray. And another sign is an impending feeling of doom. So they just feel like they're going to die. In fact, if your patient ever says, I don't know what's wrong, I just think I'm going to die, take their word for it and get them to the hospital. So now, angina versus MI, because we truly can't differentiate between the two in the field, we're going to treat them the same. So still make sure the airway is open and clear, bleeding's controlled, give oxygen based off the pulse ox reading, give them aspirin, and then assist them with their nitro, get them out to the hospital, meet with ALS, and transport them to the cardiac hospital. Now, this aortic aneurysm or dissection, this is something that it can be very critical very, very quickly. So our blood vessels are under pressure all the time, and this pressure eventually can cause parts of the blood vessel to sort of wear out, kind of like a bleb on a tire, and then rupture. And this can happen, high blood pressure is usually one of the leading causes. Smoking also is a risk factor. And there's probably some other ones I can't think off the top of my head. But depending on how large this tear is, they may bleed out very quickly or very slowly. But if it's a major tear, they can bleed out in a matter of just a minute or two. And if it is a aortic aneurysm, they might be having some chest pain with this as the aorta tears in half, and that hurts. They may have diminished blood flow to one side of the body or the other, so you may have weaker pulses on one side or the other, depending on where the tear happens. And typically they will then begin to show signs of shock with low blood pressure, narrowing pulse pressure, anxiety, tachycardia, and tachypnea. Now, if this happens down in the abdomen, we call it a AAA, or abdominal aortic aneurysm. And these patients will typically have like low back pain. And if you look at their bellies, if they're skinny enough, you might actually see this mass in their belly kind of pulsing with every heartbeat. Kind of weird to see. Don't push on it. Don't poke at it, because you might tear it and then your patient dies. So we have three layers three layers to a blood vessel, and the dissection or the tearing starts and kind of works its way through the inner, the middle, and then the outer lining. And as we have this tearing, they will have pain, and they usually describe it as kind of like a tearing tearing pain, and that's just a good, if they ever say that, tend to think aortic dissection. Now, other things can go wrong with the heart. It's not just an MI and angina. Heart failure is one. So with heart failure, here the heart is wearing out. And a lot of times this has to do with a history of high blood pressure. So the heart's just having to squeeze really hard to pump the blood through the body or to pump the blood through the lungs. And over time, that builds up muscle, but then over time, that muscle begins to fatigue and wear out, and that's heart failure. Or we could have had some small MIs, myocardial infarction, some small heart attacks, and small parts of the heart are dying. Even though it's still pumping like it's supposed to, it's not pumping as well as it used to because it's parts of it are dead. And that then leads to heart failure. So when we have heart failure, the blood begins to back up. So if the right side of the heart's failing, if you think about your drop of blood through the heart thing that we do, we have to kind of work that backwards. So you know the right side of the heart gets blood from the superior and inferior vena cava. Now because of gravity, if the blood can't pump very well and it backs up, most of it's going to back up into the inferior vena cava and then down into the feet. So the feet are going to be swollen, and we call that pedal edema. In fact, you can even press into like their feet or their shins, and you can press in and press in and press in, and depending on how deep it goes, we may call it +1, +2, +3, or +4 pedal edema. And there's also this thing called weeping pedal edema, which there's so much fluid buildup in their feet that it's oozing out through their skin. Really kind of nasty. Now, if the left side of the heart is failing, you think about that, then the blood backs up into the lungs. And then we have fluid buildup in the lungs, and we have crackles and congestive heart failure, and they're coughing up pink frothy sputum, and they can't breathe. And if we lay them flat, they stop breathing, and they like to sleep in a recliner, sitting up, and all that. And that would be more left-sided failure. Typically, if you have one, you're going to eventually have the other. So look for both signs or signs and symptoms of both. Now, when you have both left and right heart failure or complete heart failure, you can have something called cardiogenic shock. And that means the heart or the pump just cannot beat strong enough anymore. And it has basically just started to fail. So without the pump working, the blood's not moving. And your blood pressure begins to drop. So now we're going to have somebody that looks real gray, pale, cool, clammy skin, real weak pulses, maybe not even a radial pulse anymore. You only have carotid pulses. And that's all signs of cardiogenic shock. So the congestive heart failure, I mentioned the neck veins and the pedal edema. Here's a picture of somebody's feet that are pretty swollen. And once in a while, you will have the blood back up into the superior side of things. And you look at their neck veins, and you can see this guy has his neck vein out. And that's an indication of heart failure also. So then congestive heart failure usually means that, or congestive heart failure does mean that the lungs are filling up with fluid. And we have congestion in them, and that can make it really, really hard for them to breathe. So typically with congestive heart failure, they're going to be a little anxious and a little confused because they're not getting enough oxygen. They're getting cyanotic, tachypnic, tachycardic, coughing up pink frothy sputum typically, crackles when you listen to the lungs, can be real short of breath. As this progresses and it's more of a chronic type condition, they may end up with some abdominal distension and an enlarged liver. And then if you look down at their feet, you can see that pedal edema. Not a whole lot we can do for that pre-hospitally other than make sure we keep them sitting up. Now they're already cyanotic, they're short of breath, they're going to have a real low pulse ox reading, so we're going to give them high flow O2. If for some reason their blood pressure is high, nitroglycerin can actually help draw some of the fluid off the lungs by dilating all the blood vessels. And then the biggest thing for people with CHF is they need something called CPAP. Again, that's continuous positive airway pressure. That's something that we can do as EMTs. We're going to cover that in lab, how to do that. Hypertensive emergency, high tensive pressures. This is high blood pressure. As I mentioned a little bit ago, we used to think 120/80 is normal. We now are trying to get to 110/70. The lower the blood pressure, we seem to have less risk of stroke and heart failure and other issues. So we're trying to get to that. Some high blood pressures are caused by some condition, and sometimes they're just on their own and we don't really understand. But we know things like somebody being overweight, somebody being inactive, too much salt on the diet, all leads to stress, all lead to hypertension. People get hypertension, and it builds up slowly, typically over a fair amount of time. And most of the time then, because it took a while to build up, we want to take a while to bring it back down. In fact, there's something called essential hypertension. So as blood pressure goes up over days, weeks, months, years, it gets high enough, and then if the person puts their arm in the blood pressure cuff at Walmart and goes, oh my goodness, it's 200 over 120, they call us, we show up, and then we give them a medication to drop it very quickly, we can actually cause strokes. So we want to make sure that we bring it down slowly at that point. There might be some reason why the blood pressure is high. The body may be trying to compensate for something. So gone are kind of the days that we think blood pressure is a huge, huge issue. Now, if they're having a severe headache, a nosebleed, blurred vision, fatigue, those are all signs that the blood pressure has gotten too high and is causing some issues, and it does need to be brought down. We can take them to the emergency department where they can bring it down, but a lot of times people's blood pressure, especially if they know they have a history of it, they just didn't take the medicine. And if they take the medicine like they're supposed to, it'll come back down. But we always err on the side of safety. We take them to the hospital and let them get checked out. Not much we can do for high blood pressure in the field. Just kind of leave them sitting up. We can give them a little bit of oxygen if we think that'll calm them down or bring it down some, and just let them chill and rest. And keep them calm. No lights or sirens or anything like that. Just try to relax them. Realize when we're checking blood pressures, and we'll cover this in the vital signs chapter when we practice this, to truly get a good accurate reading, they're supposed to have been resting for about 5 minutes. You're supposed to measure it at the level of their heart, and their feet are supposed to be flat on the floor. And we don't get that opportunity to do it exactly like that in the field, but that's kind of the best way to check blood pressures. Now, the ultimate cardiac issue is a cardiac arrest, and I'm going to go through this fairly quickly because we covered this in CPR class. But just remember, cardiac arrest, the heart has stopped and is not pumping, so we have to pump for it, and we do that with CPR. Now, the rhythm typically is out of sorts, and for most adults, the rhythm has gone into ventricular fibrillation, and we need to defibrillate that. So start CPR. As soon as the AED arrives, we'll use that, and then as soon as it shocks, we're going to immediately resume CPR.
A normal heartbeat rate and rhythm is called normal sinus rhythm. The heart's pumping action is driven by electrical stimulation within the heart muscle. The heart's electrical system allows it to beat in an organized, synchronized pattern. Every normal heartbeat has 4 steps. Step 1. As blood flows into the heart, an electrical impulse from an upper area of the right atrium, also known as the sinus node, causes the atria to contract. When the atria contract, they squeeze the blood into the ventricles. Step 3. There is a very short pause, only about a fraction of a second. And step 4. The ventricles contract, pumping the blood to the body. A heart normally beats between 60 to 100 times per minute. Electrical signals in your heart can become blocked or irregular, causing a disruption in your heart's normal rhythm. When the heart's rhythm is too fast, too slow, or out of order, an arrhythmia, also called a rhythm disorder, occurs. When your heart beats out of rhythm, it may not deliver enough blood to your body. Rhythm disorders can be caused by a number of factors, including disease, heredity, medications, or other factors.
Kind of a cool animation of what happens with some dysrhythmias there. So let's talk about a few medications here. Nitroglycerin. Again, we'll spend some more time with this stuff in pharmacology. But when we're looking at medications, we need to know a little bit about it. So this comes typically in one of 2 ways. It comes as a tablet or a spray. And the indication for it is what we think of as cardiac chest pain. Not just any chest pain. They could have been shot in the chest, and we don't need to give nitro for that. I'm sure they're hurt, but not that type of chest pain. So it's cardiac chest pain. Contraindications would be if we think they're hypoperfusion or shock. So if their blood pressure is less than 100, heart rate's over 100, we're not going to give nitroglycerin. We also don't want to give nitroglycerin if they're allergic to it, which goes really for any medicine, or if they have had an erectile dysfunction medication in the last 24 hours. We give it as one tablet or one spray underneath the tongue, and we can do that every 3 to 5 minutes, and we typically will not give more than 3 nitroglycerin. And this may lower the blood pressure, so make sure you check a blood pressure between each dose of nitroglycerin, and watch for them to have a headache and maybe a little bitter taste in their mouth after we administer it. Now, there's a few things that we need to talk about with young and old and women and diabetics when it comes to chest pain. For starters, pediatrics don't typically have MIs, so if a child suddenly collapses, it's almost always because they have a congenital defect of some sort, which means they had some heart rhythm or channel, I call it a channelopathy, so a problem with the sodium-potassium pumps or calcium channels in the heart. All that has to do with the electrical side of things. So they had a problem with that. So typically these patients then need to be defibrillated. So a sudden collapse, and we see this sometimes like with the kid playing basketball and collapses on the court, or the one playing softball or baseball or volleyball and collapses on the court or the field. That's usually one of these, and they need to be defibrillated. Now, shy of that, if a kid is in cardiac arrest or all the other reasons, are almost always respiratory in nature. So for most kids, the defibrillator, other than that sudden collapse, isn't going to do them a lot of good because they really just need oxygen. And actually for a child, good CPR may be enough to bring them around. Now, we still use the AED, just like you would any other case, in case they are in VFib, but they really, really need oxygen. Adults, on the other hand, they need that AED pretty darn quick, or as quickly as we can get it there. So there's all sorts of different defects in here, and I had a karate student that actually talked to me. She's older, I wouldn't consider her a kid. She's in her mid-20s, and she said, I was just told about this patent ductus ovalis or something like that. She didn't really know what to call it. And it was patent foramen ovalis, which means she has a hole in her heart. And she's probably always had it, something she was born with. Because when when the baby or the fetus is growing and it's still in the womb, it doesn't need the lungs. It's not breathing. It's getting the oxygen from mom. So you have all these little holes that basically allow the blood to not flow through the lungs. It flows through the placenta. But when we're born, obviously the kid needs to breathe, so then we switch over and all these holes are supposed to seal off. Sometimes they don't, and that's just part of the congenital heart defect. Most of the stuff is identified if it's going to be a problem within the first few weeks of life. The kid kind of fails to thrive. Sometimes there's some medications we can give. Sometimes they have to go in their surgery and seal up the holes. Now, geriatrics. So there's a few things with geriatrics. For starters, there's usually a lot of medical history with them. So they may have a lot of other things going on with them that we need to watch out for that may make this harder for us to diagnose. And a lot of times we kind of downplay syndromes or symptoms because they don't really want to go to the hospital. And as we age, we don't feel pain as much. So a lot of times our geriatric patients just don't really feel the chest pain. They might just feel sick to their stomach and a little short of breath, and they don't know what's wrong. They just kind of have this bad feeling, so they call us. And really they're having an MI. I want to mention before we get too far, well, let me wait until the very end. Never mind. Let me get through the rest of the assessment stuff. So typically our scenes are safe with these. Our PPE is pretty normal. We don't have to do anything abnormal with that. Scenes are good. We do want to get ALS en route for chest pain if we don't already have them there. Normally there's just one patient, and normally we don't have to think about C-spine. I like the picture of this guy because he has something called Levine's symptom or Levine's sign. We see he has his fist clutched to his chest, and that's almost always a sign of an MI. We don't see this as much in women as men, but when you see a guy doing that, making a fist and holding it to his chest, he's probably having a heart attack. And it's just a weird thing that people do and they don't even realize they're doing it. So when we go into one of these calls, I need to be thinking about how am I going to manage the chest pain, and of course aspirin and nitro and oxygen all come to mind. But then also they need to go to the heart hospital. They need to go to the cardiac hospital, the one with the cath lab. And again, locally that's North Alabama Medical Center, but I want to take them to that heart hospital versus a local community hospital. Do your assessment just like we always would. Get your vital signs, get your pulse ox, and as soon as we got our pulse ox, we can decide whether we need to give oxygen or not. And at this point in time, we're going to start asking them questions. So we want to ask them this OPQRST, which works really good for defining pain. So what were they doing? What was the onset when the pain started? Does anything provoke it or make it worse? Does anything make it better? Have them define the pain for you. Is it sharp? Is it dull? Is it achy? Is it heaviness? And don't lead them. Just have, and I might give them a couple of terms like, describe the pain to me. Is it kind of heavy? Is it sharp? How would you describe it? And then they'll tell you through it, or talk you through it, how it feels to them. And then does it radiate anywhere else? And what I mean by that is a lot of times I'll say, so you said you have some chest pain. How about your neck, your back, your shoulders, your arm, your jaw, your face, your stomach, any of that hurting anywhere? And let them then say yes or no to that. And then we ask them on a scale of 0 to 10, how bad is their pain? And typically with anginas, we'll get numbers like 4 or 5. When people are having MIs, a lot of times they're like, on a scale of 1 to 10, my pain is a 17, or my pain's a 13. They just say it's terribly high. But get that number, and we're going to compare that like before and after we give nitro. And then the time is how long has this been going on? Because for the cath lab to be able to do their magic, we have to get them there within about 6 hours of the onset of the pain. And if it's been longer than that, then we need to consider other options. So I need to know exactly when the pain started. And that is also important in this thing called fibrinolytics. And fibrinolytics are not used probably as much now as they were maybe 10 years ago. But these are what we used to call clot buster medications. And we could, not we in EMS, but typically in the hospital, they would give these and they would hopefully dissolve the clot in the heart and then restore normal blood flow to the heart. These would be used if your hospital didn't have a cath lab nearby. So if you were, Red Bay Hospital and a patient came in with chest pain, and of course North Alabama Medical Center is the closest cath lab and that's 45 minutes away. Well, time is muscle, so they may give a fibrinolytic and let it dissolve the clot before they even get to North Alabama Medical Center. And you may be thinking, well, why not do that all the time? Well, there's a lot of complications for that. You have a lot of little clots in your body that you probably don't even realize. And this would be really bad to have a clot like in your brain that dissolved, because then they would have a stroke. And we found that about 5 to 7% of patients that we gave this to would have a stroke. And that's a pretty high number. So we want to use this very cautiously. But anyways, somebody's having chest pain and you're thinking you might be having to give fibrinolytics at the hospital, we want to ask if they've had any recent trauma, if they have any brain injuries, if they have any strokes, if they had any brain cancers, any recent surgeries, because these are all things that would make us say, no, you're not getting fibrinolytics. In Alabama, we actually have a fibrinolytic checklist that we're supposed to go through, and it's really for strokes, but we can also do it for people that we think are having heart attacks. Get your vital signs, and again, your partner can be doing this as you're doing your assessment and asking questions. Make sure you listen to the lungs, listen to the heart, look for that neck vein distension, look for pedal edema, and ask your sample and OPQRST questions. Now, I think somebody's having an MI. As we mentioned a couple of times before, oxygen, let them be comfortable, give them aspirin, nitroglycerin if they're not in shock, and then get ALS and transport. Now, this is where I do want to mention, because we're almost done with the presentation, there's a couple of things that are different for women, our elderly, and diabetics. All three of those feel pain a little bit differently than the typical younger male. And younger, I mean 40s, 50s, 60s. So those in their late 60s and 70s, women and diabetics just don't seem to feel the same cardiac pain. So they're not going to complain as much about chest pain. They might feel pain worse another way, but when it comes to heart attacks, they just don't seem to have as much chest pain. So they have much more vague signs. They feel kind of tired and weak and short of breath and sick to their stomach. In fact, a lot of times women kind of feel like they have a flu and they're not going to the hospital when they're having a heart attack. We call all these silent MIs, and that's a real concern. So if you're ever called to somebody who says, I don't know, just not feeling right, something's wrong with me, a little short of breath, a little sick to my stomach, don't Don't rule out a myocardial infarction. That may be what's going on with them. Problem is, it's really hard to diagnose until we get 12 leads or blood work. And the 12 leads we can do in the hospital blood work. 12 leads we can do on the ambulance. Actually, we do a 15 lead now, and then in the hospital they can do the blood work. So I said we want to give that nitroglycerin at least every 3 to 5 minutes, as long as their blood pressure stays up. So we got to keep reassessing them and giving it every 3 to 5 minutes, max of 3. The aspirin we're only going to give one time. So give your 4 baby aspirin, let them chew them up and swallow it, and we're not going to give them any more than they're good for 24 hours. There is VFib. That's what it looks like on a monitor. Our AEDs know how to analyze that. And then if we look inside the chest, which obviously we can't do, but this guy could because he's a surgeon, we see the heart there covered in fat, fibrillating. And here's the 2 paddles. Gonna put the paddles on and kapoom, shocked him. Now they only shocked him at probably about 15 joules. We normally shock at about 120 to 200. And then we see it starting to beat normally. And if we look back on the monitor, there we go. We see we got a normal QRS complex again. And that's just so cool. But that's what we can do with our AEDs. We just do it through the chest wall versus internally like that. I just thought that was kind of cool.
This is a 57-year-old gentleman presented with a...
Pause it, and I'll include a link later if you want to watch it. Just because this video is getting a little long, but this is a really cool video of what happens in a cardiac catheterization, and I kind of like to talk through it in class, so we'll show this one a little bit later. So I hope that helped with your understanding of cardiovascular emergencies. Again, you got any questions, shoot me a message in Moodle, on Facebook, and YouTube, or just wait and ask me in class.